Welcome back, everyone. I hope you had a good mini break. We're back and we're going to be with Dr. Laura Belland, who's going to be coaching us through our next topic, which is symptom management and specifically part one, and specifically shortness of breath, constipation, nausea, and anorexia. So let me tell you a little bit about Dr. Laura Belland. Dr. Belland is an assistant professor of geriatrics and palliative medicine at the Icahn School of Medicine at Mount Sinai. She is passionate about the integration of geriatrics and palliative medicine into undergraduate medical education and is currently the co-director of the school's third-year geriatrics and palliative medicine clerkship. Dr. Belland is also regularly teaches in the Geriatrics and Palliative Medicine Fellowship and was named the 2024 and the 2025 Palliative Medicine Educator and Clinician, respectively, by the graduating fellows. Dr. Belland received her medical degree from right here at the Icahn School of Mount Sinai, and she was inducted into both the AOA and the Gold Humanism Honor Society. She completed a family medicine residency at Columbia, NYP, and followed that up with an integrated geriatrics and hospice and palliative medicine fellowship here at Mount Sinai. And I'm so pleased to be able to introduce her to be able to give us our talk on Symptom Management 101.
Thank you so much. Thank you so much. Happy to be here. We have a lot to cover today, so I think we're just going to dive right in. I have no disclosures. So we're going to start with constipation. And I think it's always a good idea to review what actually constipation is because we talk about it a lot, we ask patients about it a lot, but there are actually some definitions to what constipation is. So, and some criteria. So the first is, what is the frequency of bowel movements? The typical average patient should be having a bowel movement or will be having a bowel movement about every 24 to 72 hours and could be going 1 to 3 times a day. There should be no excessive straining. There should be relative ease of evacuation. The consistency should be relatively soft, and there should be a sense of complete evacuation. If the patient is saying that they do not meet these criteria, then you can pretty much rest assured that this is the technical diagnosis of constipation. And always good to remind ourselves what are the possible etiologies. So certainly diet, lack of fiber, lack of water, sedentary lifestyle. When we move, our abdominal muscles are helping our bowels peristalse, so that helps us stay regular. Of course, if there's underlying bowel disease, medical conditions such as hypothyroidism, and also iatrogenic, I feel like we often forget how many medications that we add on that can actually be quite constipating, not just opioids, but others. And then what can we do about it? So there are many different types of laxatives. I'm going to put them into categories: bulk forming, osmotic, stimulant, lubricant and surfactant, and then we're going to go over the specific ones for opioid-induced constipation or some other ones. So starting with bulk forming. So the way that these work, they help absorb water to make the stool softer. They work in the small and large intestine. The examples are psyllium, methylcellulose, dietary fiber. Osmotic. Osmotic works by attracting or retaining water in the bowels. This also works in the small and large intestine. This is where you have your Miralax, your polyethylene glycol, lactulose, sorbitol, any magnesium-based products, your sodium phosphates. Stimulants. These are acting mostly in the large intestine. They directly act on the mucosa. They stimulate the myenteric and Auerbach plexi. And these are the ones that we commonly use, such as senna, also bisacodyl. And then I put on here the Cascara sangrata because I guess a lot of people actually really do use this. I have not used this myself, but apparently it is quite effective. Lubricant and surfactant. So these help maintain a smooth surface of the stool and lowers the surface tension to allow water in. This works in both the small and large intestine. Examples are mineral oil and docusate sodium. And then if you have specifically opioid-induced constipation and it is refractory to the bowel regimen that you've already started, you can consider using a peripherally acting opiate antagonist, such as methylnaltrexone or naloxegol. If you want to try something else for your geriatric folks who may have chronic constipation, not from opioids, but they just have chronic constipation and all of your other laxatives have been unsuccessful, you could consider something like lubiprostone, also known as Amitsa. It's a chloride channel activator and it increases fluid in the lumen. Or Motegrity, this increases motility. Or Linzess, you've probably heard of Linzess, if not used it yourself for your patients, and this increases fluid in the lumen. How long does it take for these to work? Sometimes I think people forget that not all laxatives work quickly. And in fact, some can take quite a while. So Miralax, if you see Miralax all the way at the bottom, technically Miralax can take around 24, even 72 hours to actually start to take effect. Docusate sodium, I know some people love it, some people find it completely ineffective, might start to work a little bit earlier, as do your bulk forming laxatives like fiber-based products. But if you want something more immediate, of course, always going to be your enema and your suppositories like bisacodyl. And then if you want to use oral and you want something a little bit more fast acting, that would be your magnesium products. And then bisacodyl senna typically will produce a bowel movement in about 6 to 12 hours. The reason it's given at night is because the bowel is the most active in most people in the morning. So this is why you give it at night. And then by the time the person wakes up, the senna will have started to work. And ideally, that's going to help them have a bowel movement. Now, moving on to shortness of breath. So shortness of breath, or also known as dyspnea, the way that patients talk about this might come in multiple different forms. So they might say tightness in chest. Air hunger, usually we say that, but maybe they can say that too. Or they're having difficulty breathing. They might say that they're unable to inhale completely, or that you notice, and they also notice that they're working quite hard to breathe. Dyspnea is quite common in the end of life. 49% of patients in the end of life. 78% of cancer patients report dyspnea. And of course, we know that there are so many different diseases that are associated with dyspnea. Many pulmonary, of course, but also cardiovascular disease can have dyspnea. And certainly others like neuromuscular disorders, anemia, metabolic acidosis could cause a dyspnea. And so always be good to be thinking about what is the underlying etiology of the dyspnea rather than just looking at the dyspnea, because this will also help you decide what is the best treatment. So if somebody is reporting air hunger as their dyspneic sensation, it could be that the origin of this is a chemoreflexive activity in examples such as COPD or maybe an advanced phase of an asthma attack. And your treatment, you would really want to reach for your bronchodilators or maybe some non-invasive ventilatory support or a CPAP. If they're reporting increased work of breathing, this might signal that there's activity of the cerebral motor cortex in something like an ALS or a neuromuscular disease. And here you would absolutely want to reach for your mechanical ventilation if that's within goals, or your non-invasive ventilation. Chest tightness. So this could be a bronchospasm. And the origin is that there's stimulation of slowly adapting receptors in the large airways. So of course, bronchodilators. And then rapid breathing or tachypnea. So this is often due to stimulation of pulmonary C fibers in things like interstitial lung disease, pulmonary venous congestion. This is where opioids could be helpful, but also continue with your other non-pharmacologic management, such as high flow. And the most important thing, I think, to recognize is that it's not just the pathophysiology, it's not just the diseases I mentioned that drives the dyspnea. It's actually this multifactorial model, the breathing, thinking, functioning clinical model that all goes into breathlessness. So it involves the breathing itself. So there's inefficient breathing or increased work of breathing. Functioning is the person just very deconditioned. Their chest wall and their accessory muscles are also deconditioned. Maybe they have a lot of sarcopenia. They're essentially, because of that, they're also doing reduced activity. They have a tendency to self-isolate. They're not really moving around that much. And then the thinking. Is some of this driven by anxiety or distress because they're having thoughts about dying or misconceptions about their disease, and their attention to the sensation more than thinking about other things? And when you combine all of these, they basically feed into one another. And so it won't just be about treating the underlying disease, but actually thinking about all the components and how you can tackle all of these different components. So what are some of the ways? First, of course, you would want to assess, is this acute versus chronic? How severe is it? And what is the prognosis of my patient? Is this somebody who has only weeks to live? Is this somebody who actually still has possibly years to live? So first, starting with breathing techniques. So some people prefer to try breathing techniques first since it's non-pharmacologic and it's pretty easy. You might have heard of something called the box method. Basically, you tell the patient to identify a rectangle in the room. Usually it could be a TV or something like that. And on the short end of the box, they're going to inhale. On the long end of the box, they're going to exhale. And they keep doing this and practicing this until they feel control of their breath. There's also some support from a handheld or bedside fan because it can stimulate the trigeminal nerve, and then this can also aid with the sensation. Of course, if there's hypoxia, oxygen. If there's not hypoxia, some people, of course, still do tell us that they have a subjective improvement in their dyspnea. Certainly wouldn't want to remove it if they're finding benefit. But if there's not significant hypoxia, it's probably not going to be that helpful. Bronchodilators, as we discussed, diuretics, of course, if they are having volume overload, and then the thinking. So different things for thinking like CBT, relaxation techniques, a little bit of data behind acupuncture, mindfulness. Benzodiazepines here can be helpful, especially if there's anxiety. And for the functioning, pulmonary rehab, activity promotion, so actually encouraging the person, you need to move more. Moving more will help you gain strength. Moving more will help your respiratory muscles. In turn, your dyspnea will hopefully start to get better. And this is also wrapped up with pace activities, so energy conservation. So some people forget that, they can't walk 10 blocks. They're going to get very winded, and then they're going to get very discouraged. And helping them to realize that maybe 2 blocks at first, really conserving their energy before they go on to the next one, but encouraging them to continue working on that. And obviously, if you need to go to a pharmacologic approach, opioids can be given in all different types of routes, both in long-acting and short-acting. Corticosteroids, this is where the prognosis comes in. If you have somebody with a shorter prognosis and you're not so worried about the long-term risks of corticosteroids, obviously discontinue your IV fluids, bronchodilators, and we already talked about the non-invasive methods of delivering air. Now moving on to nausea. So nausea, as you probably already know from all of the pathophys that goes into nausea, it is a very complicated pathway because there are multiple different receptors that can be involved. And really important to try to think about where is the underlying chemoreceptor that I'm trying to identify, because that's going to help me choose my antiemetic. So for example, if it's something in the vestibular system, then the transmitter would be acetylcholine or maybe histamine. An example would be a skull tumor at the base of the skull tumor. If you had something in the gastrointestinal tract, like if you had an impaired gastric emptying, so here you have your dopamine, your serotonin. In your cortical, you have GABA, histamine. So it's important to always think, which part of the body do I think the nausea is coming from? And then which chemoreceptor is it that I'm going to try, or neurotransmitter that I'm going to try to target. And then here are your classes. So this is helpful for me to try to remember in my mind as I'm trying to think of which antiemetic do I want. Do I think that there's more dopamine involved in this pathway? Do I think there's more histamine involved? And then I go by class and I see which antiemetic has the most effect on which of these receptors. So if I think that dopamine is really involved and I think there's some histamine, then maybe compazine would be a reasonable choice. But if I don't think that there's a lot of histamine and I think there's serotonin and dopamine, then metoclopramide would be the best. So it really just depends on how you think the pathway is involved. And then, of course, there are some others that we must be thinking about, especially with our patients who are receiving chemotherapy. So those would include the neurokinin receptor antagonists, apripitant and fosapripitant. And this is going to depend on the emetic risk of the chemotherapy regimen that is being used, and whether you will also pair it with a serotonin, a glucocorticoid, or something like olanzapine. And then other categories that we can sometimes use would be dexamethasone, dronabinol, or you could use your benzodiazepines. The non-pharmacologic approaches, so trying to avoid any strong smells or other triggers, of course, eating small, frequent meals, limiting oral intake during periods of extreme emesis, relaxation techniques, alcohol swabs, ginger and peppermint, and then biofeedback. I have yet to see a patient really truly be able to actually get biofeedback because of insurance, but there is some data that biofeedback can be helpful for those who have been able to access it. And lastly, anorexia. So anorexia is very, very complicated, multifactorial. It probably involves many things, including inflammatory cytokines acting at the hypothalamus, alterations in appetite regulating hormones, of course, medications that we're giving. If there's any underlying depression or eating related anxiety because they've had nausea in the past, or they've gotten vomiting, or they've gotten pain in the past, any of their comorbid conditions that might be leading to anorexia, fatigue and debility, just the virtue of thinking, I have to get up, I have to go to the refrigerator, I have to make myself a meal, I don't have the energy, I don't have the ability to do this. Naturally, if they have pain, this is going to cause some anxiety. Of course, if they have gastrointestinal pathologies, so if they have a mass that's causing intrinsic or extrinsic compression, or if they've got significant constipation, mucositis naturally would be a very, very difficult thing to have and try to eat. And of course, dysphagia and odynophagia. And if they've got alterations in their taste or alterations in their smell, and just nothing seems appetizing because they just cannot smell and taste it. And if there's xerostomia, if they are so dry that every time they try to eat something, it's such a chore in trying to swallow it. So of course, always try to treat the offending cause if there is a reversible offending cause. Lifestyle modifications. So I often will ask my patients, what is your most favorite food? Maybe we should just target that for now. And sometimes there's actually benefit to trying to get the person to do a little bit of activity and stimulate the appetite that way. Our nutritionist colleagues can be wonderful in helping patients to identify high calorie, high fat foods that maybe won't be so arduous to eat and that they like. And then, of course, normalizing. So I think we've all seen our patients whose family members really are trying to get the patient to eat. It's part of the culture. It's a symbol of love, but actually normalizing that in very serious illness and especially end of life, anorexia is a part of the process, and helping the patient and helping the family manage their expectations. But of course, if medications are wanted, first line now in recent years with more and more data is olanzapine. You could also consider progestins such as Megace. One Cochrane review showed that in patients, they had a 25% improved appetite and 1 in 12 had improved weight. The drawbacks are there is this risk of thrombophlebitis. So in patients who have malignancy, might be a bit more risky. And if somebody's on it for a long time and you abruptly withdraw, have to be aware of the potential for adrenal insufficiency. Corticosteroids can sometimes be used, such as dexamethasone. Again, though, this depends on the prognosis of the patient and whether they have a significant time and you want to avoid the complications, or if they only have days to weeks, and it's okay to use these because the trade-off is the benefit of them feeling like they're eating. There's some good data for dronabinol in the HIV/AIDS patients. And then miscellaneous, mirtazapine gets added a lot. I think for people who have clinical depression and anorexia is a symptom of that, it can be helpful. Though if there's not, and it's really more due to their cancer, the data are pretty clear that there doesn't seem to be clear data that it is as helpful. And then, of course, if there's early satiety because they have gastroparesis or slowed movement of their bowel, then giving them Reglan about 30 minutes before a meal could be helpful to improve their appetite. And that is it.
Hi, thank you so much for that great talk, and thank you for targeting some of the symptoms that we frequently see in palliative care and in geriatrics. Um, and also, I just loved that you went through the mechanisms of different medications as well. I think that was really helpful, and will solidify our knowledge. Couple questions that came up in the chat. One question is, so oftentimes as patients might become more confined to bed, and caregivers are finding it, are having to take on more of the tasks of, for example, helping patients get cleaned after they have a bowel movement. I've heard complaints of patients wanting more control over their bowel movements. Are there some laxatives that you feel like might be more helpful and predictable in their, I guess, in when they will work for patients who kind of want more control when they're using their laxatives?
Um, the only way that I have in my experience has been when constipation is quite severe, it's chronic and it's quite severe, and the person benefits from something like a suppository, because that is when typically the patient will choose to have a suppository placed, and pretty effectively we can get a bowel movement at that time. What I have experienced with the oral laxatives is it can really vary, because if we give a little bit too much Miralax, then the bowels are too soft. If we don't give enough Miralax, then the bowels are too hard. I have found, I personally like Senna a lot, because I think once we get Senna on board at night, every single night, it can be more reliable. But in terms of really predicting bowel movements, the only time I have been able to help patients decide when they really want to is if it's long-standing chronic constipation and they actually prefer to use something like a suppository and really control it.
Thank you. And then with regards to anorexia, we see that in so many different disease processes. Are there, and you mentioned this to some degree in your talk, but I'm just curious, perhaps with patients who are have more advanced dementia, for example, do you have suggestions for medications to help with anorexia at the end of life with dementia, or do you focus more on counseling patients and families that it's an expected part of the disease, or
Yeah,
perhaps both?
yeah, I mean, definitely the latter. I think it's one of the hardest parts of dementia as it progresses is the loss of appetite, and then of course when they start to pocket food or they start to have significant dysphagia. Helping families to understand that there has been a disruption in the brain's ability to actually detect the hunger signals. And so, the most common concern is that my loved one is hungry. My loved one is hungry and they can't eat. And so a lot of counseling to the family that really they're not really feeling that hunger. That's what's driving this. And when we see them not wanting to eat, it's okay to support them in other ways. I do know some of my colleagues do like medications like olanzapine in that case. The antipsychotic effect can help with the appetite. Of course, that's going to be risky in our patients with advanced dementia. I would only reach for something if family were so insistent that it was going to improve their loved one's life. Most of the time, I'm able to convince families that it won't help and it's not necessary, and usually they're okay with it after that.
Okay. And I guess that's one other question. How do you approach that kind of counseling where you're talking about the risks and benefits of a medication, for particularly for anorexia?
So I actually go straight to the emotional component first. I find that once I name what is driving the patient and the family's fears, um, and how much we rely on food in all of our cultures as a symbol of love, as a symbol of health and wellness. And once we can really talk about what it means for the family and the patient, and then the trade-offs of the medications. Some of the medications may help gain fat, they may not help gain muscle mass, which ultimately is what we want. If the medications are not having significant side effects, then, okay. But I really do thoroughly go through all of the risks and let them know that in most cases they may not help. And so not to have high hopes or high expectations. And I find that most people, once they understand the disease process that's underlying the anorexia, and we can name what it is that's driving them concerns, and focus on what they actually like. So if they want to have a piece of chocolate, if they want to have a spoonful of ice cream, and that's really what they want to target for the moment, focusing on that.
Great. Thank you so much. Thanks for this really great talk and for answering these questions. I appreciate it.
Thank you.